Thanks.
Okay, I'll go for my talk.
Sir, are we permitted one comment? Permitted one comment?
Yeah.
Thank you. Very nice case. I think you must consider the possibility of an LV clot. You must consider the possibility of an LV clot which came from your anterior wall MI and that broke off and went into your RCA. Or look for another source of clot, because the ease with which your wires have gone in such a young patient, such a large thrombus load, if you had an AWMI say 2-3 days ago, small clots often form in the LV, but they can break off.
There have not been non-obstructive blockages in both these vessels. They were critical occlusions. Once we wired it, RCA had 90%, LAD had 90%. So it was atherosclerotic disease. There is no doubt about that. It was not purely thrombotic.
Can you go down? There is a PPT. Go down further. You opened the wrong. No, this is not my talk. There is another talk. Can I use my laptop? This is my talk from hall B actually. This is my talk from hall B. I have another talk in hall C. Different. See, I'll be talking to you about left main with dominant circumflex. So this is a collection of a few cases which would tell us what you do with dominant left main circulation. So this is a kind of a case where the moment you engage a guide catheter, the patient's blood pressure would drop. So we were actually with a diagnostic guide catheter. The moment you see, you had to withdraw the guide catheter. So you have to be very, very alert when you are dealing with dominant circulation. So in this particular case, once we had enough information, you can actually see a slightly different technique. We had to really stretch the osseum, so we have put two balloons at the same time from the single guide catheter. I have seen some cases where people have brought in two guide catheters, one from each groin, to achieve same kind of result. And then you have occasionally a CTO where the dependence of left main lesion is going to be equally important. Like here is a case where you can see the RCA is completely supported from left. So when you're addressing the left circulation, you have to take into account that the entire coronary circulation is dependent on this kind of or lesion. So you have to be quick, you need to do a perfect job. This was a case where you have a stent put in about 14 months back. The operator felt that the side branch can be ignored, but look at this. This is a very dominant left circulation. And 14 months later, the lesion has become very critical, giving severe angina. Addressing this is extremely difficult. You have to think what strategy you're going to choose since you already have a stent in place. So we did what we can call as a double culotte. There is an old stent going to LAD. We bring one stent, and again here, the point we discussed that the left main stent can go towards circumflex because it's a very large circulation and probably matching left main diameter better than the LAD. So you have a stent going to circumflex. So this is like culottes with the old stent. And then we go through this to put one more stent in LAD and achieve this result. So this is like double culotte since there was already an existent stent. Now, also, when you have a dominant circumflex, be a little bit futuristic. Like in this case, the stent is placed from left main to LAD. However, we took care to dilate just the strut which were going to the side branch. This was a 44-year-old, so you have to be good to him in case if he develops lesion in the circumflex circulation. So always preserve the access to the side branch by dilating just the strut. Don't get your balloon down too much, but it could be just at the mouth of the lesion. When you have a lesion like this and a dominant circulation, you need to make sure that the result is perfect. Culottes generally becomes my first strategy because it gives a very complete metal cover, and possibility of restenosis is perhaps lowest in our experience of 200 odd cases whenever we have used a culottes technique. It is reasonably quick compared to culotte. Culotte thus gives you a full metal cover, and of course it's kind of a fallback strategy too in case if you decide not to stent. The standard steps of culottes we will not go through, but it generally ends up with a good case with high pressures. DK crush, the current favorite of many people, again a very important way in which you can get a complete metal to cover the bifurcation. So it will give a full metal cover. It will also not miss the final kiss. I think this is very important that when you do DK crush, you'll almost always get a final kiss, and that's why DK crush in left main bifurcation becomes a very important technique. So typically in this case, you put a stent in LAD, put a stent in circumflex, have a little bit metal projecting in the left main, crush it with a balloon, do your first kiss after recrossing, always do part at a correct step, and finally don't forget to do what people call it as a report. Like when you do a kiss here, we always bring these two balloons back and do a final inflection. But having done that, bring in a single 4.5 or 5.0 balloon for left main to get the osseum completely flared up. To make, see with two balloons, we have a more of an oblong kind of dilatation. So this has to be perfected with a single balloon towards the end. Now this is what we worry about. This is a case, this is the same previous case, and patient comes back to us with a restenosis about 3 months later. So restenosis, whenever you get in a bifurcation left main, the maximum probability is at the mouth of the circumflex. So I strongly believe that the ossia have to be very, very well prepared, especially the circumflex osseum. So generally, we would not stop thinking about cutting balloons. So cutting balloon is almost always done. This particular patient, we had done everything. Despite that, you have ISR, which I guess can be addressed with a drug balloon. The mini crush, again, when you have a suitable angle, is a reasonable strategy. In this particular case, again, our stent is going from left main to circumflex, matching diameter with circumflex, and second stent placed towards LAD. T-stenting, again, a possibility, especially if you have an angle like this. Like in this case, the angle is clearly 90 or maybe more 90, in which case T becomes a very easy technique. So put your first stent, generally cover the major circulation when you put the first stent, and the second stent, in this case, we have placed from ostium towards LAD. So in many of these cases, you will find the left main stent is going towards circumflex. That is primarily because the circumflex is a very dominant circulation. In this case, the stent is going towards LAD, ostium is well covered, and then you do final case, report, and a good result. So all techniques that you normally follow can be used even when the circumflex is dominant, but always remember that dominant circulation takes the speed. So you have to be very quick. If you're very slow, the hemodynamics can really be troublesome. And always end up with IVUS or an OCT, so that you know you have done a complete job on any given case. So this was the T-stenting which we have done in an angle which was very suitable for T-stenting. ISR, once the circumflex dominant is, patient is coming back, surgery should be high on your thinking list. So this patient had one stent in the left main ostium, which is working well. The second stent, which was placed many years back, was here, and patient has come with an ISR to this circulation. What you also find is through this ISR, you have a very big ramus which is going through the ISR. So when you start addressing, your stent, of course, is going from left main to the critically dominant circumflex, but you also need to protect the ramus. So our first stent is placed in ramus, second stent is placed from left main to circumflex, and by this way, at the most you may miss doing a final case, but you have placed two stents in good location, and this is how the stents were placed. Unfortunately, again, the patient has come back with an ISR in this location, so there is no option now. The patient has to go for bypass surgery. V-stenting, again, you have to make sure when you do a V-stenting like this that the IVUS or OCT confirms that there is no lesion in the distality of the left main, in which case you can certainly do a V-stenting. This patient came back with an ISR, but we had nothing in the left main, so no metal in the left main, so we could easily address the left main circulation. So to end up, when we have a dominant circumflex, you must have a perfect acute result. In this acute situation, we just entered left main to LAD, and the patient was saved, an acute ST elevation MI. There would be a strong bias towards two stents because the circumflex circulation is clearly dominant. So in this kind of situation, I would probably prefer two stent by choice. Then preserve access to side branch, very important. Like I told you, in these kind of cases, we will open the strut to the side branch for futuristic use. Then stent can easily, definitely be placed from left main to circumflex if it is matching diameter Like in this case, actually the stent is placed from left main to ramus because this was a huge artery. IVUS to the side branch, very important if you're not going to address. So many times we say it's provisional and we'll end up with single stent. So do IVUS OCT to see the mouth of the circumflex, whether it is well preserved. And you have to plan your strategy properly. If there is an LV dysfunction, you would certainly use balloon, aortic balloon pump. And of course, there is a strong possibility of ISR. And if you have ISR, you would of course think of handling the ISR, or else you need to take surgery into consideration. Thank you for your attention.
Thank you, sir. Only one small doubts actually. Whenever I see the subset of isolated ostial circumflex of non-dominant vessel without left main and without ostial LAD, these are the gray zones. Which type of strategy and management we have to treat? We did some.
So you are talking of 001.
Yes, exactly. So we did only a cutting balloon followed by DEB actually in these subsets. We have a good result on the follow-up. Any suggestions, any advices, these type of subsets?
Yeah, actually just for the ostial LAD, whether to compromise the entire left main LAD, that's an issue. Like I showed you the ISR, the stent was placed the way you are saying, cutting balloon and just the stent at the ostium. But I think it's a very fibrotic hard lesion at the circumflex mouth. So whenever you deal with stenting of this subset, you must have enough metal proximal to as well as distal to the lesion. So most of the time, I think you'll have to go left main to circumflex. If it is a big disparity in diameter, of course, do the way you are doing, just the circumflex. But medical management also can be an option.
Thank you.
So the next speaker is Dr. N.O. Bansal. So acute thrombotic occlusion of non-dominant artery presenting with inferior wall ischemia and atrial fibrillation.
Myself, Dr. Gurkirat Singh. I am presenting this case on behalf of Dr. N.O. Bansal. It is a 30-year-old male presented with a chest pain of since 3 years, not a known case of any major illness, non-smoker, non-alcoholic. On examination, pulse was 150 per minute, irregular. BP was 90 by 56 millimeter of mercury. Troponin was positive. ECG was showing atrial fibrillation with fast ventricular rate, and ST changes were there in 2-3 AVF. As the patient was hemodynamically unstable, we gave injection amiodarone and DC shock was given. ECG was repeated. It showed sinus rhythm with the minimal ST elevation in 2-3 AVF. Patient was having ongoing chest pain and again developed atrial fibrillation. Then he was taken for coronary angiography. Echocardiography showed no regional wall motion abnormality. Coronary angiography showed normal left system. Left system was dominant. Right coronary artery was thrombotically occlusion, proximal. So PTCA was planned for RCA. The lesion was crossed with the filter FC wire with support of Minitrek 1.56 millimeter balloon. Lesion was further dilated with the Mosaic 2 into 12 millimeter balloon. Result after balloon dilatation was TME2 flow. Lesion was stented with Zions Expedition 2.5 into 18 millimeter stent. The result was TME3 flow in the vessel. Final result was TME3 flow. Post-procedure ECG showed complete resolution of ST changes and patient was in sinus rhythm. Take-home message, conventionally right coronary PTCA is carried out in cases labeled as dominant with PDA and PLV arising from RCA. The present case is very unusual, having presented with atrial fibrillation with fast ventricular rate, with chest pain and mild ST elevation in inferior lid with positive troponin test. Right coronary angiogram showed freshly occluded artery proximally, hence distal status could not be known till artery was opened. However, this procedure on RC helped to stabilize the patient symptomatically with abolition of recurrent atrial fibrillation and resolution of ST changes.
Yeah, though you're saying it is non-dominant, it is supplying reasonable territory both in right atrium and right ventricle.
Yes.
It's giving good branches and it took a good stent also. So
I think whenever we are dealing with troponin positive, I think the bias is clearly towards doing something. So I would definitely put a wire, do a balloon, and then take a call whether it needs a stent or no. But up to this, you can definitely go. Then if you realize the artery is too small, can be ignored. I had one patient who actually presented with ventricular fibrillation as a presentation. And at the end of the angiogram and wiring, we just left him alone because the artery was extremely small to be stented. So the arrhythmia presentation especially doesn't correlate with the quantum of ischemia. It could be just that it's responsible for the arrhythmia, but it's not an important artery. So in your case, it looked like an important artery.
Sorry. No, when we have an infraoral infarction, it always tells us if this is atrial fibrillation, it's a proximal RCA. So it doesn't matter whether it's dominant or non-dominant. If the sinus node is occluded, if there's occlusion of the RCA proximal to the sinus node, you will get atrial fibrillation. So that in fact can tell us that if you open up the flow, even if it's a small one, if the flow to the sinus node is restored, then the atrial fibrillation gets controlled in the acute setting.
with the availability of 2 millimeter stents now in the market, some of the lesions which we were leaving earlier, where we were doubtful whether to stent or not, I think now probably...
Yes, in the evolution of small vessel stenting,
yeah.
the non-dominant right coronary artery is presenting as acute coronary syndrome. Now they are tackling with the small vessel stenting. We did also a couple of cases like this.
Next presenter is Dr. Kush Kumar Bhagat. He'll be presenting on left main LED D1 bifurcation, how to treat. He is from Jaipur, Eternal Hospital.